On behalf of the CLL Advocates Network, I'd like to welcome you all to this session on the CLL 101 CLL Basics. I share this platform. My name is Michael Rynne, and I share this platform with Pierre Aumont from ELLyE in France, and Dr. Brian Koffman from the CLL Society. What we're going to try and do for you today is we're going to try and explain the CLL basics, to explain to you who we all are. My wife Jan was diagnosed with CLL in 2011, and in 2014 she was treated with novel therapy, had to travel to another country to gain access, and that led us on a road of advocacy, and we had to learn all about the basics of CLL from that day. And also I'd like to welcome Pierre Aumont. He's a CLL patient diagnosed in 2011. Thankfully he's in watch and wait. He's a steering committee member of CLAN. He's our vice chair, and he's also a board member of ELLyE in France. There's also Brian Koffman, who everybody knows well. He's diagnosed in 2005, and he's been treated multiple times. Anyone that's ever seen his story, it's a very interesting story, and it allows other patients to plan their path by kind of following patients like Brian. He's a co-founder and chief medical officer of CLL Society, and he's also a steering committee member of CLAN. Now, to move on to the talking about CLL, CLL is called chronic lymphocytic leukemia. It has a prolonged clinical course because patients live with this disease for a long time. Most patients diagnosed have few or no symptoms, and they usually are diagnosed when seeing a doctor for no other reason. It's the cancer cell is a particular type of it's a B lymphocyte, and it's a cancer. It's a B cell cancer, and you'll hear quite often through these sessions the B cell is very important for a person's immune system. It's a cancer of the white blood cells, and leukemia literally means white blood. Will I move to the next? Now, chronic lymphocytic leukemia can come with two different names. Many patients can be diagnosed with a disease called SLL, or small lymphocytic leukemia. But this causes a lot of confusion in our community, because in fact SLL and CLL are identical disease. It's just on the presentation. The difference between SLL and CLL is where the blood cancer is located. CLL has most of the cancer B lymphocytes in the bloodstream, like leukemia, whereas SLL has most of the cancerous B lymphocytes in the lymph nodes and lymph node tissues, such as the spleen and tonsils, like lymphoma. SLL is diagnosed when there's more than 5,000 monoclonal lymphocytes in the blood, and CLL, as I've explained before, is both a leukemia and a lymphoma. We'll go to the next slide. Now, all our blood cells are formed in the bone marrow. The bone marrow is actually the production center of all the cells that our body and our blood needs to function. The bone marrow is where all the cells that travel around the blood are created, including the clonal B cell that has become CLL. As the disease progresses, the CLL cells can crowd out the bone marrow. When this happens, all the other cells that the body and blood needs will reduce in number. This is one of the indicators to treat a patient. You can see from the slide that the B cell is important for the immune system to function. The B cell formed in the blood, in the bone marrow, and to put a bit of context, and for patients maybe to get a bit of understanding of what's going on, is that if you have CLL and your CLL progresses, these CLL cells can impact the bone marrow. You sometimes hear patients saying that, oh, I was diagnosed with CLL, and when they did a bone marrow biopsy, my bone marrow was infiltrated by 80% CLL. And this can mean that the other cells in the blood, they can reduce in number, so a patient can become anemic, and they may pick up more infections in the time of the disease. If I go to the next slide. So as we explained earlier on, the CLL is a cancer of the white blood cells. All blood cells come from the blood stem cell. This slide kind of explains that where our patient community had a problem with their B lymphocyte, you can see on the right-hand side that from the blood stem cell, the lymph node stem cell, the lymphoblast, and then the B lymphocyte and the T lymphocyte, and then the natural killer cells. But the B lymphocyte is what we're interested in, because that's the cell that the mistake was made, that your clonal B cell became cancer. And if the problem with your cancer went in the other direction on the left-hand side, you have a myeloid leukemia. And you can see actually where this slide is actually important to actually point out that your B lymphocytes and your T lymphocytes, your natural killer cells, they're so important in the immune system. And you'll hear a lot through all the sessions throughout the CLL Horizons conference, how important the immune system is and how much this cancerous B cell impacts the immune system and makes the immune system not function properly. So we'll go to the next slide. Okay, so to go on to this slide, this kind of explains to patients where they can maybe run into problems as their CLL progresses. As we shown in the earlier slide, your CLL forms in the bone marrow, and from the bone marrow they go into the bloodstream and they end up in the lymphatic system. And this slide shows where the lymphatic system, and actually to show you, it's not green, but they put the color green in just to kind of point it out or differentiate between the body. But the CLL flows through the blood and it's into the lymphatic system. It can cause lymph nodes to enlarge, including the spleen. This diagram shows the areas of the body that the cancer can affect. Patients can feel full after eating small amounts because their spleen is enlarged. And this is kind of some of the symptoms that patients can have. Patients, I've mentioned, how can have increased amount of infections. We'll move to the next slide. Okay, so look, this slide shows how your CLL formed. It's a massive expansion of a single B cell or a B cell clone that became cancer. It's kind of an important slide. It's a technical slide to try and explain, but it's patients as their CLL forms and it increases in number, it may not reach numbers that will cause them difficulties in their lives, which means they may have asymptomatic disease. Many of these patients can have low number of these cancerous B cell lymphocytes, and that's another disease, or not another disease, or maybe it can be called a precursor to CLL, but it's called monoclonal B cell lymphocytosis. A lot of patients that have this condition, not all of them will actually develop CLL, but it can be a precursor to CLL, but many can live their whole lives without it. And in our advocacy, you sometimes have patients coming forward that have this condition and they're very, very concerned. And in research, we would love to see a way of maybe differentiating these patients that will never develop CLL because of the worry that the cancer diagnosis will cause. To say that as well, that patients that then develop CLL, they may never develop symptoms that they would need treatment. And I know that Brian Koffman will talk about this earlier on. We'll go to the next slide. So this is what doctors see when they take a sample of your blood and they put it under a microscope and they see these smudge cells, and these are the clonal B cells or the CLL cells. We'll go to the next slide.
Thank you, Michael, for that introduction and making my job easier here. For everyone, welcome to the conference, and I appreciate the opportunity to share some basic CLL information. And what you're going to find is that we're going to go over topics over and over again. So I'm going to talk a little bit about the diagnosis that Michael talked about, and you're going to have lectures specifically on these areas later on. I'm going to talk about small lymphocytic lymphoma, and I'm going to talk about what numbers are important. So we'll be reviewing a lot of that same stuff. So, as Michael hinted at, it's the most commonly diagnosed blood cancer in adults in the Western world. And it's usually discovered on a routine exam. Someone comes in for a different problem. Let's say they're going to have a surgery for a hernia repair, and they're found to have a high white count. They have no symptoms, and they're surprised when the doctor tells them they have leukemia. So how does the doctor make the diagnosis? You don't need to have just 5,000 lymphocytes, more equal or more than 5,000 lymphocytes. They have to be identical or clonal. And the way that's done is with a specific test called flow cytometry. And flow cytometry uses lasers to look at the surface of the cells, proteins. These are called antigens or CDs, clusters of differentiation on the surfaces of the cell. And the classic markers, the classic proteins seen on the surface of CLL cells are CD5, 19, 20, and 23. You don't have to memorize that. But this is important because there are other types of leukemia and lymphomas that can also cause your lymphocyte count to be greater than 5,000. And the only way you're going to be certain that you have CLL and therefore get the right treatment and the right management is to have a flow cytometry. So you might have a white count of 30,000, but unless we know that it's clonal B cells that are positive for CD5 and CD19 being the main two markers, then you don't know for certain you have CLL. That's why flow cytometry is necessary for the diagnosis. So let's go over a little bit what Michael talked about earlier, and let me just make sure that there's no question about this, because the whole topic of MBL and SLL is confusing, because CLL, as Michael pointed out, is both a leukemia and lymphoma at the same time. It's leukemia because it's in the blood usually, and it's lymphoma because it arises from the lymphocytes. So if there's enlarged nodes and or an enlarged spleen or both, but the count is less than 5,000 B lymphocytes, then the diagnosis is SLL. So if the nodes are enlarged or the spleen is enlarged, but there's less than 5,000 of these cells in the blood on the count, then it's SLL. This is assuming that someone's done a biopsy, looked, and found these typical CD5, CD19 positive cells. But what if there's no enlarged nodes, no enlarged spleen, and there's less than 5,000 B lymphocytes in the peripheral blood? Then the diagnosis isn't CLL, it isn't SLL, but it's what Michael referred to, monoclonal B cell lymphocytosis. Monoclonal, one clone B cell, as we learned. Lymphocytosis just means lots of lymphocytes. Now, there are two types of monoclonal B cell lymphocytosis that Michael referred to. One is the LC-MCB, which is the low count, and that almost never progresses to CLL, but is very common as we age. And then there's high count, which is a small percentage does go on, HC-MBL, which goes on to become CLL. So this is getting a little bit into the weeds, but this is how it's diagnosed. Staging in CLL is of mostly historical interest nowadays. Staging is extraordinarily important in breast cancer, prostate cancer, colon cancer. With the new targeted therapies that you'll be learning about during this conference and the new options that are available, it's still of historical interest and of some interest to know what the staging is. But we usually advise patients not to pay a lot of attention to the staging, because you often can have a very high stage CLL at the time of diagnosis, but have a very excellent prognosis and life expectancy. So it's not a great idea to spend a lot of time on looking at the staging. And I've included these here for your references. And of course, the US has its own way of doing things, and the Europeans have their own way of doing things, and there's significant overlap. You will see this in a lot of papers, but it's not of critical importance to memorize this. What I will point out is important is to notice that the disease is more advanced, not based on any white count number here, but based on having low platelet counts, which is called thrombocytopenia, that means low platelet counts, or having anemia, low hemoglobin. That's what really matters in both of these systems. It's an extraordinarily rare disease compared to the big four cancers like breast cancer, colon cancer, prostate cancer, and lung cancer. And depending on where you live, you can see that it's not a common disease. And that's why sometimes when people see a general oncologist, they do not get the excellent care that you get if you can go to an area that specializes in CLL, that have doctors who work specifically in CLL and related cancers, because most patients being so rare, the doctors who take care of them don't have a lot of CLL patients in their practice. One of the first questions people ask is looking backwards and saying, what caused my CLL? And we really don't know the cause in most cases. There are two exceptions, though. The first is Agent Orange, which is a defoliant that was used in Vietnam and in the US and in other countries, from what I understand. Anyone who was in Vietnam and was exposed to Agent Orange, all their care for their CLL is covered by the Veterans Administration, because we know that it increases your risk of developing CLL. There was a question about radiation, and the background on this is, I'll divert just for a second here. After Hiroshima, there was not an increase in CLL, but we now believe that's because the incidence in Japanese is very low. After Chernobyl, there was a significant bump up in the incidence of CLL. So we believe radiation is an important factor. One of the things that people ask, is there something I can do to prevent CLL? Can I exercise enough? If I eat the right foods, if I drink enough green tea, if I take the proper supplements? And the answer is there's no proven way to prevent CLL, but of course, having a healthy lifestyle, diet, exercise, sleep, stress management, all of that is going to help prolong your life with CLL. You can't catch CLL from anyone else. And some CLL is familial, but usually it's not. But it's not uncommon for people who have CLL to find that they have another family member who has a different kind of leukemia or lymphoma. That's not uncommon at all. So as I said, most common adult leukemia in the Western world, the average age is 72. But people in their 20s can get it, and the age seems to be getting younger nowadays. As we're doing more routine blood tests, we're finding it more often. It's more common in men than women, depending on who you read. That can be almost twice as common in men. It's more common in Eastern European Jews. It's less common in Africa, and especially less common in Asia. This is a word you're going to hear a lot talking about CLL, heterogeneous, which is just a fancy way of saying it's variable. And the reason that I point this out is CLL is not one size fits all kind of disease. Some 20 to 25% of CLL patients never need treatment. But yet a small percentage have a very aggressive cancer that needs immediate management. Most people fall somewhere in between where their cancer can be watched, and Pierre is going to talk about watch and wait or active observation later. But this is an important statistic to understand. You have a 1 in 4 chance of maybe never needing any treatment for CLL, and even a greater percentage of patients who need treatment can expect a normal life expectancy with the modern therapies. And here's an example of this, saying that here, 8 out of 10 patients, more than 8 out of 10 patients are going to be alive 5 years after their diagnosis. And this is data that's now 9 years old. The data is even better now with the new novel therapies we have. Every decade, the survival improves in CLL. So this has been touched on already, and this will be a recurrent theme. So CLL is a disease where there's this accumulation of these dysfunctional white blood cells, and they don't do a very good job of fighting infections. They also don't do a very good job of monitoring for other problems, such as second cancers. And up to 50% of CLL patients will develop a second cancer. Skin cancers are particularly a problem. They can also make the immune system quite dysfunctional. So not only do they make it inadequate, so you're immune deficient and have trouble fighting off infections such as pneumonia or COVID-19, but it also can make it so it's disrupted and starts to attack itself. And this can lead to what are called autoimmune, where the body attacks itself, most commonly in the blood. That's called autoimmune hemolytic anemia, or it can attack the platelets, and that's called ITP, or immune thrombocytopenic purpura. And this can present in a small percentage of CLL patients. As I said, the other problem is they can accumulate and cause problems. So the spleen can get enlarged, it can push against the stomach, making it difficult to eat properly. The glands can swell. They can, in theory, obstruct organs, cause problems. They can be a significant cosmetic issue. They can be very uncomfortable. And when they're in the bone marrow, they can take over the bone marrow. And as Michael mentioned, this is called infiltration. And they infiltrate the bone marrow. And it's not unusual to find people whose bone marrow is 95, 98% full of CLL. And there's no room left on the factory floor to make the hemoglobin, to make the red blood cells, to make the platelets that are needed, to make the other types of white blood cells, one called neutrophils. And this can result in anemia or low platelets or low neutrophils, which is called neutropenia. So these are significant issues. Not only do they physically crowd out, they send toxic messages out, which suppresses the rest of the bone marrow from doing its normal activity. So what are the symptoms of CLL? So symptoms from the low white blood count can be that we have flu-like symptoms. You just feel achy. It's almost like you have the prodrome, getting the flu. You feel just like you're a little bit sick all the time, and this can be from chemicals that are released from the cancerous cells. You are higher risk for infections, bacterial, viral, and fungal. If the red blood cells are low, they carry the oxygen, so that's going to make you short of breath. Some people will notice this climbing stairs or exerting, exercising is usually where it's noticed first. It's often very gradual, so it kind of sneaks up on people. People get fatigued, weak, they have a lack of energy, they need extra sleep. If your platelets are low, those are involved in clotting and preventing bruising. So people will get nosebleeds, bleeding from the gums. They can get little tiny red spots on the palate, on the roof of the mouth, or in the ankles. They can have trouble if they nick themselves with prolonged bleeding. If the nodes are enlarged, we talked about this being a problem when the spleen is enlarged, pushing against the stomach. Or nodes can be painful in the groin, in the armpits, in the neck. They can cause cosmetic issues and pain issues. And in some cases, they can push against the bowels, push against the kidneys, and cause problems there. These symptoms are this collection of symptoms. There are no A symptoms. I don't know why they're called B symptoms, but there are no A symptoms. And loss of appetite, unexplained weight loss, night sweats, and these are profound night sweats. These are drenching night sweats where you have to change your bedclothes, change the sheets. This isn't just feeling a little hot. And profound fatigue, which is not caused by anemia. These are actually quite rare in CLL, and if you have them, you should talk with your physician or have a consultation, because it suggests that something else may be going on. They do occur in CLL, but they're not that common. And remember, as both Michael and I said, that most people nowadays have no symptoms when they're diagnosed. I'm going to switch to talking about chromosomes, and people may have heard of something called 23andMe, but we have 23 chromosomes, and we get our chromosomal material from our parents, one from our mother and one from our father. And they're all identical except the 23rd, which is what differentiates male from female, the X and Y chromosome. They look like sort of two pair of pants stuck together in the middle. So there's two arms on each chromosome. The short arm, which is the P, which I remember by saying petite, and the Q, which is the long arm. And they're made up of wrapped up, compacted DNA wrapped in a protein structure called histones. So in CLL, there's these chromosome abnormalities, and they're quite common, as you can see from the statistics here. What I want to explain is that these chromosome abnormalities are not found in what's called the germline or the rest of the body. They're found in the cancerous clone that's gone bad. And as Michael showed with those electric jolts in some of his cartoons, there's hits on those cancer cells that turns them into the cancer. But if you were to take a biopsy of the skin or a piece of any other part of the body that doesn't have the CLL in it, you wouldn't find any of these chromosomal abnormalities. They're only found in the cancer. The most concerning is deletion of the 17p, the short arm of the 17th chromosome. And that is because on that, there is a gene called TP53. TP53 regulates the replication of the cells. And when TP53 is missing, cells can reproduce in an aberrant, abnormal way, and they don't get a message to stop doing that. They don't get a message to repair, and they don't get a message that they're damaged, and it's time for them to commit self-destruction, for them to commit apoptosis or cell suicide. So the absence of the short arm of the 17th chromosome, 17p deletion, is very critical because many therapies are dependent upon damaging DNA, the body recognizing the damage of the DNA, and then going into a self-destruction mode. That doesn't work if you're missing 17p. So chemotherapy, old school chemotherapy, does not work if you have a 17p deletion. Other deletions of importance are the long arm of the 11th chromosome, 11q, and that also has a mixed prognosis, but in the era of modern therapies, it's much less important. 17p is still important across all therapy lines, but less important now. 13q deletion can be good news depending on the nature, and trisomy 12 means an extra copy of the 12th chromosome, and it's relatively neutral in terms of its prognosis. There are ways that we look at this. In the old school way was to stain all the chromosomes, but the new way is to go fishing, and FISH stands for fluorescent in situ hybridization, and nobody has to memorize that. But if you look at the first on my left here, the normal pattern, you're going to see two colored dots for each color, which means there's two copies of each chromosome, which is appropriate. But if you look at the middle one, and the green dots are the 12th chromosome, you'll see that there's 3 green dots. So this is trisomy 12. And if you look at the far right one, you'll see that there's only 1 red dot, and the red dots are the 13th chromosome. And you can see that that's missing too. So this is a way to look at specific chromosome abnormalities, which is going to be important in determining what therapies might be best for you. So a mutation is a kind of DNA damage, and I talked about TP53. So there's 2 ways that TP53 may not be functioning. It may be completely missing. So if you're missing the part of the chromosome that contains TP53, then it can't function if it's not there. But it can be there, but it can be mutated and not working. And this is the common situation. People have one part that's missing and the other part's mutated. So it's this sort of double hit, and it has a role in tumor suppression, keeping cells from dividing too fast or in a controlled way. There's another mutation that's important to know about in CLL called IGHV, or immune heavy chain variable. And what's important about this is it's a suggestion of the maturity of the CLL cells. And ironically, what seems ironically at first is the mutated IGVH or IGHV, it can be said either way, are slower growing and have a better prognosis than the unmutated. And what that is telling us is the mutated cells have gone to school and have learned how to react to certain immune stimulus, while the unmutated are still in their raw kind of teenage stage and haven't been disciplined yet, and they tend to grow more wildly. So while generally a mutation is not a good thing to have, mutated IGHV has a positive prognostic factor. And again, that may play into whether or not you decide to have chemo immunotherapy. There's other markers, and these are much less expensive, at least the first one, beta-2 microglobulin, or B2M. And it's as B cells divide and grow, they shed it into the blood, and an increase suggests that there's more B cells going. There's also what other genetic changes that can be found if you do next generation sequencing, which is a more advanced and sophisticated test, which wouldn't be available in a lot of countries and is really more done in clinical research. And I've listed some of them here: Notch1, ATM, SFB31, and there's several others. There's also, again, a test that's usually done more in research, and there's controversy about what the cutoff is. Some people say 3 chromosomal abnormalities. Some people say 5 are needed to say that you have a complex karyotype. A karyotype is what is your genetic makeup. That's what a karyotype is. So you want to have no chromosomal abnormalities, but in CLL, there's, as we said, 80% of people have some kind of chromosomal abnormalities. And if you have 3 or more, depending on which research you read, 5 or more, that suggests that the prognosis is somewhat worse. Again, I would say the B2 microglobulin is important and inexpensive test, easy to do. The other genetic markers you're not going to find done in a lot of settings around the world. And are more of a research tool. Complex karyotype can also be helpful, but again, more of a research tool and not found in a lot of places. So this gives me a chance to switch over to my friend Pierre, who's going to give you some more practical and less scientific advice. And he's going to start with watch and wait, or he's got some other terms to explain that. Pierre, take it away.
Thank you, Brian, and thanks to Michael and Brian. We know all about CLL, but behind the disease, of course, there are patients, and we now are keen to talk about the patient journey. The patient journey begins often with something which is called watch and wait. Would it be better to watch and worry? I will try and explain that this is not the case, and some envisage to another wording and something like active observation, as Brian already mentioned. So if you compare with other cancers, so people are used to I don't know, breast cancers or prostate cancers. And for those solid tumors, it's important to treat the cancer as early as possible. Is it the case for CLL? Not always. So it much depends on the patient himself, of course, and his characteristic, as Brian already talked about. In EHA 2019, we had some evidence, some information about high-risk patients. Be sure that all patients are not at high risk, and for those, maybe an early treatment with ibrutinib would slow the progression. But nevertheless, and for the majority of patients, there is still no evidence of improved survival with early treatment. So that's the reason why watch and wait period is quite important and absolutely key for the following for the future of the patient. I will come back later on about that. Of course, there may be some clinical trial. I will tell about that as well. But watch and wait, watch and worry. But watch and wait rather than watch and worry is very often the best solution. Next slide. So the principle of CLL therapy. It's important to understand that prognostic and predictive testing should be done first before any treatment, because they help determining the best option that are available. Generally, the clinician treat CLL patient only when they become symptomatic and not at a particular level of lymphocyte. As Brian explained, and Michael as well, CLL is a very complex disease, and it is not only with one figure that the clinician can make a decision about treatment. Choice of available therapy vary greatly from one country to another. That's a remark which is quite important. And even within Europe, we experiment some very huge difference as far as treatment availability is concerned between, for instance, Western Europe and Eastern Europe outside the European Union. So beware that availability of the treatment may vary a lot depending on the region you are living in. New therapies are coming fast, and treatments keep getting better. If you come back 10 years ago, you had only chemotherapy, and then you had immunochemotherapy, and then targeted therapies, and then CAR T cells, and now combination of targeted therapies. So bear in mind that treatment are improving a lot for CLL, and of course it's a very good news. And a very good news, especially for those who are in watch and wait, because one year gained in watch and wait may open new opportunities of treatment. Generally, when available, targeted therapies are preferred over chemotherapy. Brian already mentioned that some situation, for instance, 17p deletion or TP53 mutation, for those cases, chemotherapy should be avoided absolutely. So that's the reason why the predictive tests are absolutely key before treatment. We know that in some countries they are not so far, and patient may be delivered chemotherapy without any predictive testing, and that's of course not acceptable. Clinical trials may be the best choice if possible, of course, but that would be, of course, proposed by the clinician to the patient, and to be discussed, of course, between the two of them. Quite important in those times of COVID-19, many therapies weaken immunity, and of course it has to be taken into account and in the way you are behaving in your normal life. So protection, of course. All decisions should be shared between the patient and the doctor. We, of course, advocate a lot in favor of patients that are maybe not expert, but active in their own disease, and are in a position to discuss their situation, their specific situation with the clinicians, and also the different options about the treatment. Next slide. So CLL is so complex that it may lead to some confusions. Clinical heterogeneity, of course, may lead to quite different scenarios. Long survival versus aggressive clinical course. It's important to bear in mind that it would be reflecting the underlying biological heterogeneity. So Brian Koffman extended very clearly what are the different characteristics of a patient that leads to quite different situation in front of the disease. So don't be surprised that there are some huge difference between the different patients related to their own characteristic, be it genetic, epigenetic, or whatever. So prognostic testing helps, as I already said, but it's not, of course, 100% predictive. It would be too simple. But, well, nevertheless, it's absolutely key to have those testing made, especially before treatment. Something quite important to have in mind: there is no curative treatment, apart perhaps from some transplants. Brian has a personal patient journey which is quite amazing, and I hope it will be the case for him. But so far we cannot speak of curable disease, but the treatment are so quickly progressing, that of course on the long run it may be cured, but we are not allowed to say that. It's not the case, not yet the case. So diagnosis and treatment initiation do not coincide at all. As I said, you may have it may last a long time between diagnosis and treatment, depending upon the situation of the patient, the symptoms, etc., the personal characteristic. And well, on the contrary of other cancers, as I already stated, it is better when it's possible. It is better to wait than to treat immediately, as far as CLL is concerned. Only some treatment will work for some patients due to their predictive factors. That's once again what Brian explained. The specificities of the patient has a huge influence on the treatment that could be proposed to them. And once again, high lymphocyte counts do not need to be treated. I mean, it's not the figure that triggers a treatment. It may be interesting, of course, to follow this figure, but it is not enough. And as you understood, it's a much more complex landscape that has to be taken into account in order to make any treatment decision. Next slide. So patient concerned at diagnosis, well, I can only speak about myself. As I heard that I had a CLL, means a leukemia, of course I was stressed. And I had to inform myself in order to better understand what's going on, what could be the future, and to understand that you may have a cancer and not have and have no symptom, and neither require any treatment. By the way, it's my case because I have been diagnosed 10 years ago and I am still in watch and wait. So, well, I hope it will last a couple of years on the top of it. But don't think that diagnosis induce treatment. It's not the case on the huge majority of the people. So after the shock of diagnosis, well, you have to be aware that you will probably have some kinds of dilemmas, confusion, conflicting choices, etc., which lead to stress. If you better understand your disease, it will be better. If you communicate with your hematologist, with your clinician, it will be better. Again, the treatments are improving so quickly that you would have to rather to consider that there is a huge hope rather than a stress. Next slide. So CLL and COVID. Of course, we are facing, as everybody knows, a very dramatic pandemic. And well, it's important to know something about CLL and COVID. CLL is a cancer of the immune system. It means that all CLL patients are immune compromised, so that their defense against the diseases is weak or weakened. So CLL patients who contract COVID-19 do worse than most, with higher rates of hospitalization, ICU admission, and death. It's a consequence of the immune immunization, of course, and that's a characteristic of all CLL patients. CLL patients must be aware of that. CLL patients have less predictable and robust response to vaccination and even boosters. It is the case for all vaccinations, be it flu or be it COVID-19. So it means that vaccination not always induce a high level of protection for the CLL patients. It means that post-vaccination breakthrough infections are much more common in CLL and can be fatal, of course. So if you have to remember only one sentence about CLL and COVID-19, is get immunized, especially through vaccination or other means, but act as if you were not. So it's quite important. So the best protection still are the barriers, the precaution you may have in your life. It means you can try and live a normal life, but with a very, very important amount of precaution. That's quite important. Of course, COVID may be but one solution, of course, against COVID is the vaccination, but why not also treatments? And we have emerging solution, and those are the anti-SARS-CoV-2 monoclonal antibodies that are promising. It may not be an ideal solution because they are expensive, generally requiring infusion, best taken very early in the course of the disease or post-exposure. And in some countries especially, there is a short supply of those monoclonal antibodies. By the time being, they are rather taken before exposure, after exposure, excuse me. It could be interesting to have such monoclonal antibodies in pre-exposure prophylaxis, meaning before any exposure. And I know that some labs are developing some antibodies, perhaps easier to use, and that could be a solution for a pre-exposure treatment. Maybe not everywhere, once again. Also for monoclonal antibodies, you have a very huge differences between the different countries. But let's say the progression is already available, be it for vaccines that has been very, very quickly developed. And now with those monoclonal antibodies, we are at the very beginning of the story. And I think it will improve as well very quickly. Next slide. So I am sure after those information we delivered that you have a lot of questions, and you will have the opportunity, plenty of opportunities during the Horizon meeting to ask your question to our specialists. Thank you very much.